Good afternoon, everyone, and welcome to our webinar today. I'm Tom Glinsky, Chief Inspector with the Board of Pharmacy, and today we have the MoHealthNet Pharmacy Program update. Today's presenters, we have Olivia Garretts, MoHealthNet Program Integrity Pharmacist, and Joshua Moore, the Director of Pharmacy Program over there, as our presenters today. So welcome both of you today, and thanks for coming to give us an update. If you haven't been on our webinars before, you are in listen-only mode. If you have any trouble, if you're connecting via computer audio, you can change and dial in if needed by going to your toolbar and using that option. This has been approved for 1 hour of CE by the Board of Pharmacy. If I'll give more information at the end of the program on how to do it, but you need to be logged in to go to webinar in order to get it under your own username. We do not give credit for those just listening by telephone. We do not submit CE to the CPE monitor, so make sure you save your certificates. And also, don't assume another state accepts this. You need to check with them to make sure if you want to use this for your CE for another state. If you want handouts, there's two places to get that. Option one's on the board's website. If you go to the upcoming events tab, there's a link there. Or if you go to the videos and webinar link, there's a link there too. On the GoToWebinar program, if you're on a web browser, on the left side there shows you where the link is for handouts. If you're on the mobile app, you have to click the 3 dots and then materials will show up, and you click that and you can get the webinar handouts there. We do record our webinars. They show up usually about 15 days or so after the close of the webinar, and all previous webinars are there if you want to go back and watch any, listen to any of those. Time permitting, we do plan to answer some questions on topic today. If you'd like to submit a question to us, go to your toolbar if you're on the browser and type it in. On the mobile app, there is up at the top right, a question mark icon you can click and to submit your questions. So now I'm going to turn it over to Olivia. Thank you again, Olivia, for coming today.
Thanks, Tom. I think this is at least my 5th time presenting, first time as a Garrett, but thanks again for letting us be here today. And just before I jump into the actual presentation, I just wanted to highlight one thing, especially in light of the recent tornadoes and then all of the messaging that the Board of Pharmacy has been sending out. We did want to remind everyone that MoHealthNet, we allow overrides for early refills as appropriate for those participants that are impacted either by tornadoes or the severe storms. Okay, so for these presentations, we always open up with a budget overview, and we do operate in state fiscal years, meaning that our budget year starts on July 1st and then ends July 30th of the following year. Oh, sorry, we might be having some audio issues, just kidding. So pharmacy is only one piece of the MoHealthNet budget, but we are a fairly significant piece. You can see that we average about 12.5% of the entire Medicaid budget going into the pharmacy program. Now, this includes your physician-administered drugs and then all claims billed by either retail and community pharmacy providers, with the bulk of the budget being to the retail and community pharmacy providers. One thing that we like to highlight that's not represented on this graph is the percent of our Medicaid budget that is used for the administration of the entire program. So approximately 1% of our budget is spent on administering the program, which is far less than your commercial insurance programs, which you'll see average about 15 to 20% of their budget there. So we really do operate efficiently, as we have only 1% paying for our overhead costs, and 99% of all the other dollar going to, or that is appropriated, goes back to our providers and our pharmacies who are servicing our participants. You might wonder what's included in our administration cost. That's going to be the roughly 250 MoHealthNet employees that we have, the actuarial services, all of our computer systems, and then even the vendors that help support the program. And speaking of vendors, we are happy to announce that MoHealthNet has contingently awarded a contract to Gainwell Technologies for a new pharmacy system that happened back on March 14th. So now we're kicking off an implementation that's expected to take anywhere from 18 to 24 months. So we've talked about percentages, let's put them into actual numbers. And looking back at the last full state fiscal year, we did spend about $2 billion in the pharmacy program, and that's out of a total $15.6 billion that was spent across the entire Medicaid program, which the entire Medicaid program is the large orange bar graph that you see. Now, $2 million does sound like a lot of money, and it really is. But thanks to the work of our rebate unit, we do collect about $1.2 billion back in rebates that then gets reinvested back into the program. And that's not only just the pharmacy program, but the other programs within MoHealthNet as well. We will get into it a little bit more on the next slide, but with the growth of Medicaid over the years, you will see that our expenditures have also grown quite a bit. This year, we are on a trajectory to be about the same in expenditures as we were last year. So I just mentioned that we've seen a growth in Medicaid over the last few years, and that's really due to two main reasons, one being the PHE or the public health emergency, along with Medicaid expansion. So both of these impacted us at about the same time. So we really do have a different influx of just how many participants we will land on each month. As of today, we're hovering around 1.2 million lives that are on Medicaid each month, and those numbers have been relatively flat since February of 2025. Just as a reminder, we do have day-specific eligibility, so if you were to ask us what our numbers would look like tomorrow, it very well could be different. And I just wanted to highlight again that even though we've seen these increases in enrollment, we have been able to continue to manage the program with just minor fluctuations in our staffing numbers. So now if we break down the pharmacy expenditures even more, you'll see that we look at them on a financial cycle, and we have two payment or financial cycles that happen every single month. I'm sure many of you are already experiencing that the specialty spend is eating up more and more of everyone's budgets, even though by and large our claims volume still remains within that non-specialty product space. Here at MoHealthNet, we are running reports that we have claims over $1,000, $10,000, $100,000, even $1 million each. There are about a dozen medications that are over $1 million for a single claim, but those are curative or transformative therapies, and Josh will get into those a little bit later on in the presentation. So our claim volume is not yet high within that specialty space, but I just did want to highlight we do have about a dozen participants that have received Zolgensma, which is the first multi-million-dollar drug at $2.25 million per treatment. When you're looking at the graph, you can see that our specialty spend, has trended at about 50 to 60 million per cycle, and our specialty spend has peaked at 135 million. And if you do some math, that equates to roughly $6.7 million are spent per day. Again, just in pharmacy expenditures. We do know that we need to expect increases as medications have not gotten any cheaper. Currently, the median price for a new drug approved by the FDA is a little over $300,000. But our pharmacy team continually monitors the drug pipeline, and not just for recent approvals, but we're also looking about 18 months into the future just to help us create a coverage plan and budget for these high cost drugs. One thing we like to mention is that we don't think a lot of folks realize is that once a drug is FDA approved and the manufacturer has signed a rebate agreement with the federal government, MoHealthNet has to offer a path to coverage for that drug. Whether we think it's an effective product or not, the FDA has deemed it safe and effective, so Medicaid is then required to offer a path to coverage. Next, we're going to take a look at the top 20 drugs by claims volume and expenditure, but we're going to start with volume. So the medications that are on this list, most people are probably familiar with. They've been around for quite some time. They are high volume drugs, but fairly inexpensive for the most part. You'll see that atorvastatin or Lipitor is our highest medication by volume, and Medicaid expansion has helped to elevate it to that spot. It used to be further down the list. Albuterol was in our #1 spot for a long time, but with the placement of the SABA limits, which I'm sure you guys are all very familiar with, we just placed those to help us ensure that rescue agents were truly rescue agents, and we've seen the albuterol drop from #1 down to the #2 spot. Overall, we don't like to put limits on rescue medications, but we found it was the most effective way that we could get the message across to prescribers that something needed to change. And I don't have it listed on the slide, but I wanted you guys to know that you should be expecting limits being implemented in the epinephrine agents self-injectable PDL edit, the glucagon agents PDL edit, and the anticonvulsants rescue agents PDL edit happening this summer and early fall. All of these limits will be very reasonable, and we really anticipate little impact to either your workflow and to the participants. Just a few examples as to why we thought we needed to implement limits here. We had a participant who received 267 doses of glucagon in 2024, and another participant who received 44 boxes of epinephrine. So not only are these limits being put in place to help protect the taxpayer dollar, but also we're hoping it leads to better patient outcomes and disease management. Next, looking at our products that have the highest expenditures for us. These are going to be the newer, more expensive products that not everyone may be familiar with, but there is one medication that we do think people are familiar with, and MoHealthNet is excited to see it grow, and that's going to be the Invega Sustenna. We all know that LAIs work really well for both schizophrenic and bipolar patients, and we believe that it should be a standard of therapy, as it's great to have a long-term therapy on board for 1 or 2 months. Something else that I wanted to call out here is that every once in a while we hear a few grumbles about some of our brand name products that we prefer over the generics. MoHealthNet is always looking for the lowest net price for a product, and sometimes that is the brand, but that's due to the rebates that we collect. Like I mentioned earlier, we are reinvesting those savings back into the program. And when we look at the last quarter, we did save around $18 million just by preferring some brand names over their generic alternatives. Now we're wanting to brag a little bit on a project that we started a few years ago, and this is Project Hep Cure. We do still have a lot of patients out there that have hepatitis C that's either undiagnosed or untreated. At the start of this project, the baseline number of participants that were treated each year was around 1,000, but now we are treating a little over 1,500 participants every year, which is a 53% increase. So it's very exciting that a lot of our patients, or for a lot of our patients and for a lot of our prescribers, 95% of patients that take Mavyret, which is our preferred product, will have a complete cure from their hepatitis C in about 8 weeks. We're still going to continue to try to push and motivate prescribers and pharmacies to help treat this disease. We've seen about 1,600 patients over that first 3 years of the program that have now received treatment that would not have been treated if we hadn't started this project. Currently, there have been over 5,000 participants that have been cured of hepatitis C since we launched the initiative. And then based on the current trends, we hope to cross 6,000 participants in the near future. So rumor has it that MoHealthNet prior authorizes every single medication in Medicaid. And today I'm going to confirm that that rumor is true. Okay, just kidding. But we do have 300 different policies in place. So yes, we do have a lot of prior authorization criteria, and it probably does seem that we do prior authorize every single medication. But over 90% of our claims are actually prior authorized electronically without any intervention from either the prescriber or the pharmacy. So every single week, our pharmacy team gets together and we discuss prior authorization criteria, and different ways that we can either make it electronic or transparent, just to overall help the need for a manual PA and just to reduce that PA burden for both pharmacies and providers. You can see in the graph, and we think that we're moving in that direction, that our claim volume, even though our claim volume has increased, our manual PAs have decreased. Now, emphasis on the manuals of PAs have decreased. Our fax volume has gone up, but we believe that's due to the inappropriate use of CoverMyMeds. Out of the 15,000 faxes that we receive each month, only 10,000 are legitimate faxes that actually require action. I am going to note that with our new solution that we're implementing in the next, again, 18 to 24 months, we will have CoverMyMeds integration. And when we do that, we hope to see continued decrease in PA burden at that time. So in the meantime, and before that implementation takes place, how can you help yourselves now with drug PA requests? It's super crucial that you're using the latest version of the drug prior authorization form just to help ensure that your requests are processed as quickly and efficiently as possible. In addition, we highly recommend that you are typing rather than handwriting the required information when filling out the form. This is just to help ensure that all the information is readable and accurately populated into our system. Again, that helps expedite the review process. Now, to utilize the full functionality of a fillable PDF file, you must download the form and then fill it out using your default browser. And I'll go into that in a little bit on the next few slides. Just overall, please make sure that you're reviewing the prior authorization form carefully and submitting any additional necessary documentation. This could include progress notes, lab results, all of that information that we need is listed on the forms. And then we also have a new pharmacy prior authorization process training, and I'm going to get into that too in the next few slides. So we did have a revamp of our website, and so I just wanted to include this so everyone is aware of where the forms are. If you go to the MoHealthNet main page, click on pharmacy. This will be one of the very first things that you see, and our forms are all found in the left-hand corner. Again, all of these have been updated to be a fillable format. So taking the ADHD medications prior auth for an example, we clicked on it within the browser, and this is what you see. If you try to fill in this form from this page, it will not work. You have to hit the download button, which it might be kind of hard to see on your screen, but it's has a little red circle around it. This will open up in a new browser where you will be allowed or welcome to fill in and type in the actual form. So for this slide at the bottom, that reference link will take you directly to the pharmacy prior authorization process training. This training gives you an overview of the PA process. It helps review the required documentation that's needed for the different PA forms that we have. It also provides further direction on how to submit these forms and then even ways to check the status of a prior authorization request. And so just as a little insight into the training, we have introduced a convenient self-service feature on the MoHealthNet Pharmacy and Medical Pre-Cert Help Desk, IVR. Pharmacies and providers can now quickly check the status of a drug prior authorization fax by utilizing the MPI, the patient's DCN, and fax date. Again, you can find more information about that within the training, and it's also in a hot tip or bulletin. Another initiative that we have seen to help reduce the PA burden is the use of diagnosis codes on pharmacy claims. So at MoHealthNet, we do use extensive medical information, including diagnosis codes, in the majority of our clinical and preferred drug list edits. This helps us gain further insight into the real world utilization of our drug products for both on and off label indications. When we get this kind of information, it allows us to improve the transparent processing of pharmacy claims. So what we want you all as pharmacists is just to get that information from the prescriber and then use that diagnosis in your process of reviewing the prescription and educating or counseling the patient. I have just an example in the instance of Flovent versus Flonase. It makes it a lot easier on the pharmacist to know if the prescription is supposed to be for allergies or asthma when the prescriber includes that diagnosis on the prescription. Not only are diagnosis codes used as an aid in educational efforts, but they also aid to potentially reduce provider burden by decreasing the number of times a pharmacy or prescriber must call the help desk for an override. We're happy to announce that we have seen an increase in the utilization in the amount of diagnosis codes coming in on pharmacy claims. A lot of that is driven by e-prescriptions, and we've been speaking at many provider conferences to also convince them to please include a diagnosis code on their prescription. So you're not the only ones that are receiving this message. We are messaging that out to the actual prescribers as well. We do think that the message is getting across. We've seen a 14.5% increase year over year, but the majority of that is still from our e-prescriptions coming across with a diagnosis code. Like I said, we have gotten a whole lot better with some of the irregularities that we've seen on diagnosis codes from last year, but just wanted to highlight the do's and don'ts. I think that we went over these last year. So just as a reminder, do only use the diagnosis code that is provided by the prescriber. Any submitted diagnosis code on a point of sale claim is subject to audit. The expectation is for the pharmacy staff to utilize that diagnosis code included on the hard copy or to reach out to the prescriber to confirm the diagnosis if a diagnosis code was not included on the initial prescription or the prescription initially. We also want you guys to be talking to your software vendor. We still have pharmacies telling us that their software vendor doesn't support the submission of diagnosis codes, but the diagnosis code is a standard part of an NCPDP transaction. Be sure that you guys are using billable diagnosis codes. And then moving on to the don'ts side. Don't let your system automatically say, oh, this is a prescription for Olivia. We know that she's a Medicaid participant and has hypertension. So regardless if it's a flu shot or Abilify, we're going to be submitting all of her claims with a diagnosis of hypertension. This is a huge red flag for us, and it shows us that you are trying to circumvent the edits or the system. Be sure that you are not just assigning a diagnosis code for a patient on your own. A reminder, in Missouri, pharmacists are not allowed to diagnose based on current rules and regulation. That's not within our scope of practice, and by making up a diagnosis, you are going beyond that scope. Again, diagnosis codes and adding them to pharmacy claims is not a way to circumvent an edit. So your pharmacy system should be set up automatically to pull the diagnosis code from an e-prescription and send it over to us. There are still a number of pharmacies that haven't figured this out technology-wise, but we are here to tell you that this is not going away. So we please ask you to work with your software vendors to have this turned on, and not just turned on, but turned on correctly so that we can utilize all of the data that is coming across. So in the pharmacy's point of sale software, the diagnosis code should be entered into the NCPDP field 424-DO without the period, or your switch should be taking the information from the point of sale claim and submitting it to MoHealthNet via the standard NCPDP format. I just did want to highlight too that the reference here is highlighted in red. We have updated where this information lives. It's going to be in the new payer sheet that just got posted yesterday, so we didn't have a chance to update the slides, but be sure to sign up for MoHealthNet News to get either a bulletin or a hot tip or even a provider blast to find out where this information lives. The do's list included using a billable diagnosis code. I wanted to throw out a few examples here. One, you should be verifying that the code is billable. So example, we have the S62.5 for a fractured thumb. This is no longer specific enough. Sometimes it will indicate whether it's the right versus the left thumb, if it's a proximal or distal fracture, if it's displaced versus not displaced. So for S62.5, it should not be used for reimbursement purposes, as there are actual multiple codes below it that contain a greater level of detail. There are actually 98 billable codes under S62.5. In October every year, ICD-10 codes are added, removed, and updated, and many become more specific. And just a reminder, don't be making up the codes on your own. They need to be coming from the provider. This is just another example, the code F20 schizophrenia. It is no longer a billable code. It really lacks the full specificity needed to be billable. So in terms of diagnosis codes, we have been evaluating what's been submitted to us, and for the most part, it has been good data. We are seeing valid diagnosis, and we can actually take that and match it up with a medical claim from the prescriber. However, we have noticed that sometimes the diagnosis codes do not match the drug. For example, if you think of Doxepin for blood pressure or Abilify for blood pressure, those don't match up. We do understand and have some grace that mistakes happen, but whenever they happen over and over again and we see a pattern, that's whenever we start to take steps to address this issue. So in the past few years, MoHealthNet has identified pharmacies and their staff finding workarounds to apply diagnosis codes to pharmacy claims inappropriately by either A, storing a default diagnosis code on a participant's profile with the expectation that this default diagnosis code would then be submitted with every MoHealthNet pharmacy claim for that participant. Or two, they were looking up a diagnosis code online based on what would make sense for the medication prescribed without ever consulting the actual prescriber. Just as a reminder, and I think folks forget this, that MoHealthNet can see all submissions and all reversals of point of sale pharmacy claims. So we can see when a diagnosis code is changed multiple times until a paid claim is received. Here is an example of a diagnosis code related audit that we have concluded now, but the pharmacy was flagged with a high percentage of their point of sale claims containing the same diagnosis code for the same participant. So you can take a look down at the drug list and see that many of them are not used for bipolar disorder or indicated for that. This participant actually had 87 claims that all came across our system with this exact same diagnosis code. Again, just another example here, taking a look at the drug list and comparing that to the ICD-10 code that was given. This is one of those cases where a diagnosis code was assigned to a participant and utilized for every single prescription. In this instance, we saw 156 claims come across with the incorrect or with this diagnosis code. And all of the ones that had the inappropriate diagnosis codes, those were all subject to recoupment. So we're still keeping the thought process of decreasing PA burdens, and so we wanted to go over GLP-1 best practices with you guys. So MoHealthNet will reimburse for one GLP-1 at a time. We also see some staff confusion on our side when we start reviewing the prior authorizations, when participants are started on a GLP-1, but then providers are submitting PAs for a different GLP-1. It makes it hard to distinguish what the provider really wants. Zepbound does not require a new prior authorization for a dose change. And also for Zepbound, be sure that we are providing all of the appropriate documentation, including the billable diagnosis code to help expedite the review process. If you have participants that have both Medicare and Medicaid, they must have the GLP-1 covered by Medicare before Medicaid will pay as secondary. Now, many of the notes that are on this screen seem directed towards providers rather than pharmacy. So why are we sharing all of this with you? We do often see that pharmacies operate as gatekeepers or maybe enforcers of policies, especially MoHealthNet policy on behalf of providers. So we thought that it was best to include that. But Zepbound, and just as a reminder, Zepbound does require a PA for all new starts, just not if you don't need a new PA if there's a change in dose. So we have many pharmacists that are still interested in enrolling as individual MoHealthNet providers to bill us for prescriptions ordered by pharmacists. There are a few steps that need to be taken to ensure reimbursement is granted and that the services that you provide stand up against any type of potential audit. So number one is just verifying eligibility through EmoMed. We know that participants are not used to checking eligibility with a pharmacy claim. So typically if a pharmacy receives a paid POS claim, it means that the MoHealthNet participant is eligible. However, providers outside the pharmacy, they do check a participant's eligibility every single day, because that's a reminder, we have that day-specific eligibility. So someone who is eligible yesterday may not be eligible today and vice versa. Be sure that you're documenting within a medical record. This document legally verifies that what care was provided, and it should be complete, legible, and concise. I know we've had quite a few questions asking for examples of what type of documentation we accept or what we expect to see. We do not dictate how the clinics and prescribers keep their medical records. And so we don't feel the same. We feel the need not to do the same with pharmacists. Make sure you're taking a look at the fee schedule for covered CPT codes and their reimbursement rates. Reminder, medical claims can be submitted either through the pharmacist provider medical system or through EmoMed. And lastly, the pharmacist provider needs to be listed as the performing provider. Billing provider will all depend on what type of agreement you have established between the pharmacy and the pharmacist. Overall, before you provide any type of service, please make sure that you are reviewing the bulletin and the manual and really reading through it. We have gotten numerous phone calls to pharmacy admin just asking questions, even though a lot of those answers are present in the resources provided. So those two references that I have listed there is going to be that bulletin and the manual. We have actually had great growth in our pharmacist provider services. We've been advocating this for several years and we're happy to see it growing, but we still need to maintain this enthusiasm for our profession. So as we have raised reimbursement rates and pharmacists have really taken to this, we brought reimbursement up to $5 million last year, but there is still a little bit of money that's being left on the table. $5 million is not a lot of money whenever you talk about spreading that over the 1,300 pharmacists that are enrolled in MoHealthNet. We would like to see the number increase, and we think that there is a plethora of opportunities available to pharmacists to help continue to grow these numbers. And the fact that we only have 164 pharmacists that are actually billing us is funny to me, because that's fewer than the number of folks who are on this call right now. So if you're on the call, we encourage you, please go sign up and become a pharmacist provider with MoHealthNet. We really would love to see the gap close between the number of pharmacists who have enrolled and those that are actually billing. Every once in a while, we do get some questions and if we have any kind of additional resources on how to submit claims within EmoMed, and we have created that resource here. So you can take a look at this whenever you have a medication that's administered by a pharmacist. So please be sure to review this resource. It would not be a presentation given by the program integrity pharmacist without mentioning more audits. So just in terms of audits and compliance, MoHealthNet is always continuing to work with Missouri Medicaid Audit and Compliance Unit to start reviewing our claims data. Primarily, we've been focused on physician administered drugs We see a lot of billing errors in that space, but we are starting to look more and more at community pharmacies just to make sure that claims are being billed correctly and that taxpayer dollars are being spent correctly. What we want you to expect, and you shouldn't be surprised to see communication from either the MoHealthNet Pharmacy Integrity versus MoHealthNet Pharmacy Admin. The Pharmacy Integrity email is a real email. It's actually monitored by myself and one of my other colleagues over at MoHealthNet. And if we do request medical records, we do expect those to be returned within 10 days, and they do not require a HIPAA release from the participant. I am going to round out my portion of the presentation with just a few MoHealthNet educational opportunities. The first one that we want to talk about are the pharmacy committee meetings that we have. If you ever want to learn more about the MoHealthNet pharmacy benefit, we welcome stakeholders, public, anyone that wants to join to come and see us in Jefferson City, or you can join virtually via Teams at one of our quarterly advisory meetings. At these meetings, we review coverage criteria, drug utilization trends, and make any types of necessary program changes. For pharmacists that do need Missouri continuing education, you can actually join these meetings to earn Missouri Board of Pharmacy CE. And it's roughly 3 hours of CE per meeting. And again, it's one of those things like Tom mentioned earlier, we don't send these to the CPE monitor. You have to keep the certificate on hand if you get audited. So you can actually find all of our meetings in the calendar of events tab on the MoHealthNet website. We do meet in January, April, July, and October of each month. There are 3 meetings in each month. That's our Rare Disease Advisory Council, our Drug Prior Authorization Committee, and then our Drug Utilization Review Board. Again, we meet both in person and virtually via Teams. If you happen to click on the calendar meeting placeholder, this is where you would find out more information. It has the team links and it even has an add to calendar functionality. And again, these are the meetings where we learn about proposed criteria or things that are up and coming and changing. So you as pharmacists can be ahead of the game by learning what will be changing in terms of criteria or PDL status if you come to these meetings. So we are very excited to introduce a new training course on proper drug billing. So this is a very convenient training. It can be completed in less than 15 minutes. And it covers national drug codes, how to determine and calculate what quantities to bill on, physician administered drugs, who should be billing for white and brown bagged medications, whether that be the pharmacy or the clinic, and a lot more information. It really serves as a handy resource to have. It includes all kinds of helpful links and just different contact information. So we urge everyone to take a look at it. And then the MoHealthNet Education and Training Unit has created a new provider overview guide, and this is for all provider types. It's not just for pharmacists, but this guide helps with questions regarding billing, eligibility, verification, and more. You can use this guide to just learn the basics of the spin down program or EmoMed or the pharmacy benefit. You can access the entire course to learn about all of the topics, or you can actually go to targeted lessons. So if you wanted to only learn about pharmacy, you can click on that. The course is also searchable by keywords if you're looking for just specific information. And the Education and Training Unit does offer live webinars, and these webinars take you through the guide, but you can also ask questions and then receive answers in real time. And now we're going to do a quick audio change and send this over to Josh.
Hi, good afternoon. Josh Moore, Director of Pharmacy at MoHealthNet. I'm going to share some really positive news about the MoHealthNet program. We were the first state to participate in a new CMMI cell and gene therapy access model. This is a national model for state Medicaid programs to figure out and mobilize the payment for new cell and gene therapies. These cell and gene therapies, as Olivia mentioned earlier, are in general multi-million-dollar therapies per treatment, and some have quite the lengthy path to administration for the patient. So we're pretty excited that the first model disease state was sickle cell disease. We actually began this model on March 1st of 2025, so just a couple months ago, and are working our way through our first set of patients. We actually now are helping other states to join the model as well and figure out all of the technical aspects to having a claim go through your system and pay at roughly $3.1 million for a patient. We want to go to the next slide. This gives you an idea of just how complicated the process is for a patient to receive one of these new sickle cell gene therapies. It's not as simple as showing up to your local pharmacy or hospital, getting an administration and walking home. This generally turns into about a year-long commitment from the time you decide with your provider that this is the right process to go through. You'll go through fertility preservation potentially as well. You will go through harvesting of bone marrow. The bone marrow then goes off to the manufacturer to alter those cells, and then the cells are reinfused into the patient. At that point, they start about a 40-day inpatient hospitalization. It can vary significantly, some as little as 30 days, some much longer than 40 days as they wait for engraftment. And then we follow these patients for about 15 years. The fantastic thing about this model is there is the ability for, if it does not work, MoHealthNet and the Medicaid program can recoup some of those costs. Now, as I talk about that, I definitely come from the perspective of we hope we never get any money back. Just like my life insurance, I hope is wasted money. I hope that we will never get money back because these treatments do work for these patients and they are cured of their sickle cell disease. Few last slides, and hopefully people are putting questions into the chat so that we can answer those when we're done. We already saw a couple of questions about who should we contact. So one of the things that we want to make sure people are aware of, we've got a couple different contacts here on the slide. Our pharmacy administration unit is going to be responsible for answering billing questions, issues. Those are unrelated to specific prior authorizations. We also have our prior authorization help desk that everybody's aware of. I could memorize this phone number. I used to work at a retail pharmacy. It's been about 15 years, but I still know the phone number is 800-392-8030, and it's option 3. I think I could dial that in my sleep. If we want to go to the next slide, staying up to date is really important. As Olivia mentioned earlier in the presentation, we have over 300 policies. Medications come out literally every single week. We have to build these policies pretty quickly for some of these new drugs as they come out because manufacturers have found ways to try to manipulate prices. A new trend that we're starting to see is these in-betweener doses that are pretty frustrating because they offer no therapeutic value difference, but they may be 100 times more expensive than those products on the market. I think of things like metformin 660 milligrams and some other items like that. A couple of things that we have on the horizon. We are going to put out some more educational opportunities. We are talking to the Pharmacy Association about how to educate pharmacists on making sure they do get paid for the pharmacist provider services and the MTM they're doing. We do not plan to put out any kind of document that says this is exactly what we expect an MTM encounter to be. We have general guidelines that are held within our provider manual that we've talked about many times, but we will not put out a template that has to be followed every single time. We think pharmacists are healthcare providers, and through that healthcare provider relationship with the patient, you should be able to document what is needed. Again, if you do have questions, you can reach out to our education unit. They are more than willing to help and answer questions.
Okay, well, thank you, Josh and Olivia, for your presentation today. We now have some time to take some questions. If you would like to send us a question, if you're on the web browser, you go to the toolbar and you can enter it there. If you're on the mobile app, you click the little question mark icon at the top right. We will answer questions that are on topic today. So if they're not related to MoHealthNet, please don't send them in today. So I'll turn it back over to you two.
Yeah, already a couple of questions came in. One question related to, will MoHealthNet still be reimbursing providers for DisposeRx packets in the Safe at Home program? No, we actually ended coverage of DisposeRx packets last year. So hopefully you are not dispensing those and submitting payments because we are not reimbursing for those products at this time. Next up, question about the time frame for Medicaid to work with CoverMyMeds. We are in the process of implementing a very large system implementation. This is the first time we will be moving our pharmacy claims processing, rebate, et cetera, system to a new vendor. So it's going to be quite substantial. It's going to take about 18 to 24 months to complete that work. So once we have completed that work, that is when we are talking about going live with CoverMyMeds for electronic prior authorizations. We will share exact details and dates as we get much, much closer. So for now, please do not use CoverMyMeds. It creates what could best be described as a garbage fax that wastes a lot of people's time at MoHealthNet. We received a question about faxes from Medicaid not including the patient's date of birth. We are not able to add the date of birth at this time, but we'll keep that in mind for future enhancements. Question about, are pharmacies expected to complete prior authorizations, or is the prescriber's office expected to complete those forms since additional chart documentation is needed? So that really depends on what the product is. There are some prior authorizations that the pharmacy can contact MoHealthNet's prior authorization help desk and get the override because we need additional details. There are other cases where we do need additional chart documentation, so it is best that the prior authorization is initiated and continued through the prescriber's office. There is somebody that's really up on the news and watching the bills go through Congress. There was a new bill passed today in the House that has not become law yet, and how that's going to affect patients. I have not been able to read the 1,000 pages just yet, but we will be watching that. And as federal regulations and statutes change, we will adapt and make sure that we put information out to our providers. Next question is, when a patient is dual eligible and primary requires 90-day supply, are we allowed to change to a 30-day supply for the secondary to cover? That would be up to the primary insurance and the secondary insurance. That's a fairly complicated question. I know that there are some insurances out there that require 90 days supplied to be dispensed. We at MoHealthNet only cover up to a 30-day supply in most cases, the exceptions being documented in our provider manual. So really, you're going to have to look at those contracts and make a decision there. There's a pretty lengthy question here, so I'm going to try and summarize it about opportunities for speaking with caregivers and billing MoHealthNet for caregiver interventions. Most of the CPT codes that we have payable for pharmacists this time are encounters with the actual patient, not with the caregiver. So we would need the provider to tell us what code it is they think should be utilized in a caregiver situation. We can research that and we can let you know, but we would need the specific CPT code and situation from the provider before we can make a determination of whether or not that would be payable for a MoHealthNet participant. I wish I had the list of vaccines memorized that are covered by Medicaid, but it is most vaccines are covered by MoHealthNet. I think as long as the board is okay with those being administered to a patient, those in general should be reimbursable, but of course you will need to check to make sure that they are reimbursable before you administer to the patient. Otherwise, that would be at your own risk and own financial potential liability. There's a great question about Direct Care Pro. Direct Care Pro, before I get into the question, we are actually discussing internally whether or not we are going to sunset that program. We do think potentially in the coming 6 to 12 months, we will sunset Direct Care Pro, and we would expect pharmacists to then move over to documenting in their own system and also to bill through either their own billing software or through Emomed. Now, the question here is for Direct Care Pro interventions, do we need to create additional documentation, or is answering the questions provided sufficient? Does that documentation need to be kept separate, or would we be able to print off the responses for an audit? You need to keep that documentation separate in your own files for audit purposes. Also, as we've talked about a couple of times, we are going through a migration to a new system. Once that new system comes online, Direct Care Pro will no longer be accessible, and it may not be accessible when we do sunset the main DC Pro application in the next 6 to 12 months. And more messaging will definitely be sent out to pharmacists well in advance of any sunset of the Direct Care Pro application. That does not mean that we are walking away from MTM or pharmacist provider services by any means. What it means is we are entrusting pharmacists to be able to do an intervention with a participant, much like we would expect a physician or nurse practitioner to do an intervention with a patient. There's a question about a discrepancy between eligible patients for billing as a pharmacist provider and successfully paid claims. I would suggest reaching out to us at Pharmacy Admin. Eligibility is day specific. It's very complex. Billing is also very complex. Some of these are very much individual based questions. And so we can look at those individual questions. Looking at the claim helps us quite a bit as we try to uncover exactly why a claim may be denying. There's a myriad of reasons why through the core claims processing, why a claim could be denied, not just associated with the eligibility or something that's readily apparent to a provider.
Okay, well, thank you for answering those questions. Let's see, before we conclude, just to let you know, we do record our webinars. It takes about 15 days approximately before they get posted on our webpage. We do have all previous ones. We had already one this year. We did one on MoPro, the new licensing system. We also gave a regulation update on that same one about a couple regulations that changed at the beginning of the year. So if you're wanting CE for the program, you must complete the post survey in order to do that. Depending on what system you're on, if you're on a web browser, you'll follow these steps. If you're on the mobile app, the questions will automatically pop up for you. But if you're on the web browser, once I say I'm closing the webinar, a screen will come up. You will click close on that. Do not close your browser, and then the survey will open up. You answer the questions and click submit. If you do not get the questions on either of those methods, you can email us at compliance@pr.mo.gov. We'll email you the questions, but you must have your answers back to us within 24 hours of the close of this webinar in order to gain CE. Again, we will mail out the certificates. We email them now. We no longer physically mail them in approximately 30 days. Save your certificates because we do not submit to the CPE monitor. So I want to thank Olivia and Josh again for coming and giving us a good program today. We thank you for giving the pharmacists the ability to answer some questions to you too. So thank you again, and I am now going to close the webinar.